Hi, everyone. Thank you for joining us today for this evidence-based mental health Google Hangout on an amazing topic with a terrific panel today. We're going to be discussing Bob Findling's paper in a special issue of evidence-based mental health, progress in diagnosis and treatment of bipolar disorder among children and adolescents, an international perspective. And we certainly have an international panel with us today to discuss this. I want to remind people you can follow us on Twitter at EB Mental Health, and if you have questions during this Hangout, please tweet them using our hashtag EBMHchat, that is hashtag EBMHCHAT. I want to introduce our terrific panel today. First, Samuele Cortese, who's a clinical associate professor of psychiatry and psychology at University of Southampton and an adjunct associate professor of child psychiatry at New York University, who's a child psychiatrist who's guest edited a special edition for evidence-based mental health and he'll outline the paper, the issue that we have. Bob Findling is the Leonard and Helen R. Stolman Professor in Child and Adolescent Psychiatry at Johns Hopkins and Director of Child and Adolescent Psychiatry and the Vice Chair there. He's also the Vice President of Psychiatric Services and Research at the Kennedy Krieger Institute, and he'll be presenting his paper. We're joined by a really terrific panel today, including Gabe Carlson, who's Professor of Psychiatry and Pediatrics and the former Director of Child and Adolescent Psychiatry at Stony Brook University's Renaissance School of Medicine in New York, and she's President-elect of the American Academy of Child and Adolescent Psychiatry, who has been doing research in this area for close to 40 years. We're really delighted that she's able to join us. Ben Goldstein, an old colleague and a terrific friend, is Professor of Psychiatry and Pharmacology at the University of Toronto. He's the Director of the Center for Youth Bipolar Disorders at Sunnybrook Health Center in Toronto and the Chair of the International Society for Bipolar Disorders Task Force on Pediatric Bipolar Disorder. And also, I hope we have in the background Carmen Moreno, who's a child psychiatrist at Hospital Gregorio Marañón in Madrid, and coordinator of the Spanish Mental Health Research Network in Children and Adolescents, and co-chair of the ECNP Network on Child and Adolescent Disorders. And as usual, we're joined by our editor-in-chief, Andrea Cipriani from the University of Oxford. Andrea, welcome to the call. I'm Michael Ostacher. I'm an associate professor of psychiatry at Stanford University and the digital content editor for evidence-based mental health. It's a long introduction. Samuele, why don't you tell us a bit about the special issue that we have that's focused on child and adolescent psychiatry, and then we can follow that by having Bob present his paper and we can have a free-flowing discussion.
Sure. So basically to celebrate its 20th anniversary, Evidence-Based Mental Health published last November a special issue focused on child and adolescent mental health. So we had a number of interesting original studies, as well as a number of clinical reviews and systematic reviews. Clinical reviews included topics such as ADHD, genetics, neurodevelopmental disorders, psychopharmacology in child adolescent psychiatry, quality of life, use of PRN medication in emergency setting, and so on and so forth. So what we asked the authors was to provide a general and comprehensive overview on the advances in their field in the past 20 years, and also to highlight future avenues of research. And we asked to focus in particular, in the spirit of the journal, on the advances in terms of evidence-based and empirical evidence out there. So one of the clinical reviews was focused on bipolar disorder, and as you mentioned, it was conducted by Bob and colleagues. And we thought that it was a good place to start today with this series of hangouts on child-adolescent mental health, because arguably it has been, and it still is in part, a quite controversial topic. So we think that this hangout will contribute to that discussion, hopefully clarifying what is not controversial anymore and what is still controversial, possibly.
All right, so first of all, let me thank you for inviting me to this hangout, and certainly it was an honor to be requested to do this review. And, you know, the purpose of the review is to sort of ground us. I think historically, the word controversial continues to come up and has continued to come up. And, you know, that with time, things that used to be unclear have become more clear. And there's a general consensus about many aspects that pertain to this topic. And the purpose of this is to, again, summarize our common ground that is based on the extant evidence that we possess. You know, we touched base on a lot of topics. You know, this includes things like focusing on the nosology of bipolar disorder across the life cycle, and certainly focusing on the fact that at least the way we define bipolar disorder in adults, it seems to at least be salient to some group of children, knowing full well that not every youngster with the behaviors that are oftentimes associated with this condition suffer from bipolar disorder, and acknowledging that so many of the symptoms of this condition are non-specific to this condition in general, and that in many ways it's the context and the longitudinal course of the condition that separates itself. Certainly, one of the other things we really focused upon is the prevalence, and one of our findings, at least based on the extant literature, is that the age at onset may actually be younger, at least in the United States, compared to other parts of the world, and the reason for that still remains unclear. The other interesting challenge that we really wanted to talk a little bit about is whether or not there's a differential presentation across the life cycle. And certainly for young people, one of the things that repeatedly is discussed in the literature is the fact that there does not seem to be distinct long-standing periods of inter-episode recovery, but in fact that these youngsters oftentimes have mood fluctuations. So with all this non-specificity and difficulties associated with the condition itself, coupled with really difficulties of lack of specificity, what we also wanted to hone in on because of this is some take-home messages that really are recurrent themes in the literature to assess clinicians who grapple with accurately diagnosing these youngsters. You know, it's the diagnosis of bipolar disorder in young people is a high-risk proposition. We know that this is a powerful condition that can substantially negatively impact and cause disability and human suffering in young people. But conversely, if you overdiagnose this condition, you are also running the risk of perhaps sentencing a youngster to a lifelong diagnosis and exposure to treatments that may not be necessary. So our take-home messages for assessment, we boiled down to 4 simple bullet points. And I just want to review them. The first one is really a longitudinal course. And that really is, you know, when people ask, what is this? It's really not just what do you look like now, but how did you get here? The other thing is this is a highly heritable condition with heritability that oftentimes is estimated at about 0.8. So if there's a family history of bipolarity, you know, it's certainly something that is something you carefully look at. Moreover, there's concerns about reactivity that oftentimes youngsters who are oftentimes very impaired suffer from. And one of the things that we thought was a very key aspect of this is not only is there a longitudinal course, but there's episodicity, clear episodicity, even if it's not associated with distinct long periods of inter-episode recovery. And the other piece, again, is that these episodes, these changes in mood, are spontaneous. Finally, because of this condition being a mood disorder, we would expect that the challenges and these symptoms would be observable in multiple settings and not simply circumscribed to a single setting. We then delved in a little bit about the treatment. We've learned a lot more about treatment. In fact, the most recent medicine to have their FDA approval changed in the United States and the labeling changed in the United States is lithium. Lithium, which is a gold standard of treatment for adults, really had a variety of different studies of different methodological stringency, and a series of studies I was privileged to lead has now culminated in a change of labeling for lithium in youngsters as young as age 7, with evidence-based dosing, as well as not only an acute indication, but a maintenance indication as well. And then we just, again, concluded a little bit about neurobiology, but the reality is in 2019, we don't have a biomarker or a blood test for bipolar disorder. And certainly our panel today can to talk about what we know and what we don't know. But one of the things we really asked for and really suggested is that we know more now than we did before. And rather than stoking controversy and adversarial discussions, but really, again, moving forward together, looking at data and doing methodologically stringent work to help answer areas where the field still needs to move forward, and our clinicians could benefit in helping these vulnerable youngsters we're privileged to treat. So I think I've talked enough. We got really smart people on the panel, and I'm, really interested in what they have to say. So let me just wrap up that very succinct summary there.
I think that's great. We do have terrific people on the panel. I want to remind people that if you're watching this live, you can tweet using the hashtag EBMHchat, and we'll see your questions and we'll try to respond to them. I think it's terrific. You know, the last paragraph of your paper, I think, is worth saying, is worth reading, Bob, to get this off the ground. Some of the prior controversies continue to be addressed with methodologically stringent research in order to constructively address existing concerns about this condition going forward. We believe it is far better to apply efforts towards advancing the field with empiric evidence. This means continuing to conduct methodologically rigorous research rather than taking tendentious positions that do not help advance the field. And I think that really succinctly describes the position that we're in right now and the opportunities that we have. So whoever wants to jump in, please do so.
Maybe I'll get started. Bob, thanks for the introduction. I think that a lot of us on the call would agree that controversy has really dissipated as data have accumulated. And just to maybe lead with the area that has ongoing controversy, which is the prevalence of bipolar disorder in people before adolescence. And to lead into that, I think that it's important to deal with the fact that there are still people who don't believe in the existence of the possibility of bipolar disorder in someone before puberty. And I think that that's an area where, you know, even in the absence of data, it's important for us as a field to get behind and recognize that there's other neurological conditions that are also relatively uncommon, but that if you're going to have, as you said, and as Bob was mentioning, an important collegial, collaborative moving forward discussion, it has to begin with the premise that it is possible for someone before the age of 13 or 14 to have bipolar disorder. Curious for others' thoughts on this.
May I just follow up on that? So when you wrote, Bob, in your paper that the controversy is mostly resolved, I guess this refers to the so-called academic controversy. When we move to the real world, clinicians, particularly in the United States. Do you think that the controversy has been dealt with properly, or do you think there is still uncertain attitudes and different practices out there?
So I think one of the things my colleagues and I have worked on is, first of all, that this was not any goal of mine when I started my career a while back. And I just had the privilege of working with an adult psychiatrist as a collaborator who had a very, very large cohort of adults with bipolar disorder. And we started seeing the offspring of these adults, and I was seeing children the likes of which I had never seen before. And that's really how I got involved in this. But it wasn't an intent to do such a thing. So again, I would only say that it was a unique cohort of youngsters that led to these questions. As far as the question about the overdiagnosis of bipolar disorder, it's important to remember that I believe there's a group of youngsters who are irritable, intermittently reactive, and explosive, who don't really fit into any nosology well. They don't meet criteria for DMDD because their mood is generally okay until something bad happens, but they are reactive and explosive. And historically, we've not really found a good label for these youngsters. And at a certain period of time, these youngsters needed a diagnosis to explain their dysfunction, and in the United States, to be reimbursed for the services they provided. And so in many ways, the real question is, a lot of the diagnoses that come from claims-based data in the United States drive a lot of these concerns. And what's interesting is I am not aware of any external validation study to examine whether the billings people put on their billing code that lead to these data have any reality based on the diagnosis that these youngsters have in real life. My colleagues and I looked at this at one outpatient clinic in the Midwest in the United States and found that the kappa was worse than chance. So, you know, before we believe that these youngsters truly are being diagnosed with something, they may not have it, but most clinicians actually know that they don't have adult bipolar disorder and are using it for practical reasons only. So that would be my one person's opinion.
Okay, so let me jump in as a person who's been doing this for many years. I agree with everything both Ben and Bob have just said. I think when I got involved with bipolar disorder, it was at NIMH, and it was arguing with Fred Goodwin about a young man who was stark raving mad, and I don't mean that in a pejorative sense. There was no other word to describe how manic and psychotic he was. And he wasn't being recognized as having bipolar disorder because he was a young person, and young people just weren't allowed to have that diagnosis. So, you know, to me, the question of developmental psychopathology has always been a really interesting one, and trying to figure out why in a condition that's clearly familial and heritable, young people shouldn't have the diagnosis. So as we wade into that swamp, we realize, of course, they can have it, they do have it. And there are questions about what is it about developmental psychopathology that differs, if anything, between children and adolescents and adults. And it turns out there are some things that distinguish them. I think the research part of that, I think even people who have a difference of opinion about what bipolar disorder is and how it looks haven't gotten into the field and haven't gotten into the controversy because they want to be contentious and obnoxious and so forth and so on. They, like anything where there's not a clear answer, they have differences of opinions. And so even the people who call those really explosive, irritable kids that Bob was just talking about, and they call them bipolar, I don't think it was just trying to get out of the office with a billing code. I think they were really, truly hoping that we had that we had a solution for those kids. It's certainly true for depression. The hope when we got into the depression business was we had a solution for this. We could save these kids from having a horrible, a disrupted mental illness course. And so, you get in there and you give it your best shot. I think a number of things have happened in the last 10 or 15 years as we've been wrestling with this bipolar controversy thing. And one of them is that it isn't a simple problem, that whatever is wrong with those kids, and we don't know what's wrong with those kids, and I've called them diagnostically homeless. They don't have old-fashioned manic depressive illness. We don't know what they do have. They don't have that. We've also recognized the fact that kids who do have bipolar disorder and who have mania, one of my things is language, and bipolar has kind of doesn't have the specificity that I want for this discussion. Mania, the kids who have mania, they don't come in with labels on them. They don't come in back, with a T-shirt on it saying, I have mania. I think you have to be a good clinician in order to separate out their mania from their comorbidity in a family situation that often doesn't have things all that well defined too. And so I think we've become somewhat humble about the fact that it isn't a easy diagnosis to make. It's one that we need to keep an open mind about, that we need to recognize we may not be able to make it right away, and the longitudinal course is effective. And we also have to keep in mind that if you come out with saying somebody has bipolar disorder and they don't, that there's equal harm that can be caused to them, keeping them away from treatments that they do need, just as missing the diagnosis can keep them away from treatments that they don't need. So I think where we don't have things wrapped up as tight as we'd like them to have, the dialogue and open-minded, discussion that you're talking about and not being obnoxious and contentious is the only way we've got.
Couldn't agree with you more, Gabrielle.
Yeah. Carmen,
yes.
Please jump in.
Can you hear me now?
Yes.
Perfect. So happy to join. This is a very interesting hangout, and I really feel that I do agree with the need of diagnosing bipolar. I got interested in the field when I got the opportunity to work with the NAMS data, and we're working with Mark Olson in this paper on the high trends of bipolar disorder, the changing trends of clinicians diagnosing bipolar disorder. And we were facing this data, and yes, you need to understand what may do something rise 40 times in 10 years. And of course, I agree with Bob that some of the things that may have happened have to do with people needing to put diagnosis to provide services. And I do understand that this is an important difference between some places in systems that we don't really need just have this diagnosis particular services. Not in every place, but it's not really a condition for that. But having said that, I really think I agree with Gabrielle. It's a problem missing diagnosis. In some of the positions that Iran has been taking, and for example, at the ECMP, there's been some position paper telling that you can only diagnose kids with bipolar disorder 1, and that there's no allowance just to think on other mood suites that may have treatments alike to bipolar disorder. And this is a matter sometimes of difficulties of believing the samples that have been reported with such ADHD.
Let me interrupt you just for a moment, because your bandwidth is a little low, so your video is breaking up. But let me ask what I think you were getting at, which is how do we differentiate what I think are episodes of illness that define bipolar disorder with diagnostic criteria, and chronic symptoms that don't necessarily do that. And I think what Gay, you were saying is, when we focus on mania as a construct, we can more easily define where things are. And I think probably this is where, both in children and in adults, we get into more controversies about the diagnosis. And if anybody on the panel would have comments about that, please do, because I think in adults and in children, chronic symptoms are different from people who have episodes that are hallmarks of what we would call manic episodes, and that's just maybe where the controversy takes place.
So let me just take it on for a minute, because I've given this some thought. As Bob and Ben know, I've been a little bit of a pain in the ass about this, excuse my language, but here's one of the things that I think has been both our strength and our weakness in diagnosis, and that is looking cross-sectionally at symptoms. And unfortunately, our structured interviews, which are the gold standard that we have, as I say, are both our undoing and our salvation. When I was first taught what I know about psychiatry, and that was at NIMH and with Fred Goodwin, you took a history. A history started at the beginning. You took a history about how the person was, your former boss. I don't know if he was your boss, Bob, but anyway, Paul McHugh talks about who you are, what you have, and what's happened to you. You want to know who you are, who the person is, who the child is. And after you get that history, and in that history, you can elicit episodes and you can elicit what the changes were. After you do that, then you go in for the kill. Then you go in for the, do you meet the criteria for mania? Do you have an expansive, elated, and irritable and energetic mood? Do you have an expansive feeling about you're better than everybody else? Do you have, reduced need for sleep? You go in for that, but you go into that after you've collected a history. And if I had $1 million, I would fund some research to see whether, in fact, you've got a different conclusion diagnostically if you put that psychiatric review of systems at the end of your history as opposed to the beginning of your history. And I have a feeling that you might, and I have a feeling that that's where I may be a little bit different from other people, because I don't have to do things in the traditional way, because they leave me alone in Stony Brook, and I get people that come in and they are willing to spend the time with me and so forth. I have that luxury to do that. So I see acute mania in children much less frequently maybe than other people, because I think I get the history differently. It's not to say I don't see it, I see it, but I think that history gathering and then doing the review of systems at the end may make a difference. And when you look back at Joe Biederman's work and the Mass General people, what they talk about is the symptom overlap between ADHD and mania, and the symptom overlap isn't going to get it for you. What's going to get it for you is the history, or at least my opinion. The history difference is what's going to give it. So go ahead and argue with me about that, because I think that's one of the areas that may make a difference.
And I'm not going to argue with you, Gay. This is Bob, by the way. So we keep on talking about longitudinal course, and so the way we've tried to address it and what we've encouraged our trainees here at Johns Hopkins to do is almost the same approach. What we do in our typical history is focus on a history of present illness, which is that cross-sectional thing that people dig into. And then when you talk about past history, usually people talk about hospitalizations and past forms of intervention. So what we've really encouraged our trainees to do, and which I encourage folks to do, is that another section that is not traditionally in the history, and I refer to it as longitudinal course. And it's not what you look like today, not what happened once upon a time, but how did you get here? You didn't just wake up one day with these multiplicity of challenges. Where did it start? How did it start? How did you get here? What did it look like in a longitudinal course. And in many ways, it's the exact same issue that you referred to with a different parlance, which is the lack of specificity cross-sectionally is not helpful. It's really how you got here and the time course of how you got here. And I learned that. You said you learned from Fred Goodwin. The person who taught me to do this was Bob Post, who also was an important mentor for me.
So may I ask something related to this? So one of the most frequent questions from my students in trainees is this. So they say, we read the papers showing that children diagnosed with the broad phenotype of bipolar, they do not become bipolar. They become depressed, or rather, they present other disorders. So they ask me, why do we need to call them a bipolar phenotype? And other students, they also go further and they say, do we really need a diagnostic label for children and adolescents with high level of irritability? Or do we need to acknowledge that probably it's a very heterogeneous group, so we need ultimately to be guided by a formulation rather than by a diagnostic label? Thinking, for example, cases of maltreatment, severe trauma, and so on and so forth. So how would you address these questions?
Samuele, let me just jump in and say that I think that at the current time, this concept of a broad phenotype of bipolar disorder isn't something that most of us on this call would call bipolar disorder. If it meets criteria, it meets criteria. If it's irritable, it still has to be episodic. So I think that for most of us spending a lot of our time in the field, we wouldn't talk about an extremely explosive ADHD kid as having bipolar disorder unless they have discrete intervals of noticeable mania or hypomania. But let me also challenge a little bit the findings of that paper on severe mood dysregulation to say that it was based on the Great Smoky Mountain study, which was a assay failure. It was not able to detect bipolar disorder in any group. And so I think some of those conclusions that served as the justification for putting DMDD into the DSM were based on faulty data. Because if a population study of 18-year-olds detects, 1 in 300 cases having bipolar disorder or less than that, I think it was 0.05%, then we can't really conclude what SMD leads to.
And this is Bob. I think one of the controversies that at least remains is because of the extant data, I personally believe, and I'd love to hear other people's opinion, but I believe, because this is my opinion, so I'm allowed to own it, is that there is this group of diagnostic orphans who are euthymic, who oftentimes have ADHD, who are highly explosive and reactive, but do not suffer from a mood disorder. Reactivity is not affect. And so from my perspective, what we've done is, rather than curse the darkness, we're now going through several long-term longitudinal sets and seeing if we can identify who these kids are, what do they look like, what is their overlap with mood disorders, what are their family histories. Ultimately, we think, based on our clinical experience, is that there is a diagnostic orphan of kids like this who we don't have a good nosology for. And instead of fussing with each other, we're now looking at them psychometrically. And ultimately, the answer is to not just make diagnostic criteria out of thin air, but let the data make them, and then ultimately field test them and to see if it validates or not. And from my opinion, that's the way to go forward, not whether or not you're right or not. Look at the data, make a hypothesis, test the hypothesis, and if it don't hold water, move on to the next or do something better. But I really do believe there's a group of diagnostic orphans that we just haven't characterized yet effectively with our nosology. And I may be dead wrong, and maybe people here will disagree with me, which is great, but maybe this is the time to find out how to answer that question.
Yeah, Bob, and I also really think that this is an important thing, because these people. Sorry, can you hear me?
Yes. Yes.
Okay, because these people are really treated with medication for a long time. There's also a dearth of possibilities to treat them in the clinics with other psychosocial interventions. This is a group that's highly resistant to, I mean, this reactivity stays longer than one would like. And of course, we shouldn't forget that these are kids and that developmentally irritability and reactivity is also heightened. So during this developmental period where they should be doing much more with their lives, they're stuck with having lots of medications. We've been recently faced with this data on the use of antipsychotics. One more of these papers like saying this increased trends in mortality also with antipsychotics. So maybe we shouldn't go to that so far, but of course we need to do, maybe we should start with a symptom-based approach, or even transdiagnostically, instead of being sticking to trying to put some sticks. The difficulty with bipolar disorder is that if you get the diagnosis, it's not that clear for how long you should be treating a kid with the condition now. So it's just your best clinical judgment, the follow-up you're doing, but it's not easy to decide, this is a 9-year-old, I'm going to treat this kid for up until he's 6. We don't know from data exactly what we need to do. Right. So these two things, I really think that are really important to be addressed.
Yeah. Gay, your microphone is muted, so you may have, Gay, your microphone's muted, so you may have to unmute. Am I missing her? Is it only me who has her muted?
I cannot hear her either.
Okay.
Can you hear me now?
Yes, we can hear you now.
Yeah, okay. It was probably just as well I was muted. Okay, so let me say, I'd like to reach out and hug Bob. Bob, you have just articulated my presidential initiative.
Okay. Will I get a hug and a kiss if I tell you we've already started analyzing data and have submitted something for peer review?
Okay, great. So because so we've got two issues here. We've got the issue of bipolar disorder in children and adolescents, which I think we can lose sight of because I think it's an important topic. We also have problems with mood dysregulated kids, children at least, who are, I think, probably more common and who are significantly impaired. And honestly, that's how severe mood dysregulation got born. The rest of you are too young to know this, but back in Y2K, when it got born, when NIMH convened this conference of bipolar stakeholders in bipolar disorder, the question really is there a difference between chronically irritable explosive kids and episodically explosive kids? And that's when Ellen Liebenluft took off with her severe mood dysregulation. But I wanted to go back to something Ben Goldstein said and amplify that a little bit. And it's not only that a lot of information is coming from the Great Smoky Mountains data, which you have to keep in mind is based on 3 months of information, okay? The Kappa and the Papa and all of those things, because they were very concerned with reliability, only cared about what you were for the previous 3 months. That brings us to the fact that even though people look at these diagnostic interviews as, the same sides of a coin, or different sides of the same coin, they're very different. And so when you get something that says what your last 3 months was, as opposed to what your last year was, as opposed to what your lifetime is, you're going to get different answers. And the second thing is a normal sample isn't what we see in the clinic. And so, if you look at their data, and I've looked at a bunch of, all of these samples where they talk about a normal population, only the top about 2% of those samples are clinically relevant to us. I have the pleasure of taking part in one of those studies at Stony Brook. And basically those disruptive mood dysregulation disorder kids who meet the criteria have T-scores of 59 in their irritability scores. A T-score of 59, that's hardly worth a discussion. Whereas the kids in my clinic have T-scores of 69 versus the kids in my inpatient unit have T-scores of 89. And so you've got not only the fact that there are severity differences, there are sample differences, and there are assessment differences. And I think if we don't get those things distinguished, we're going to continue to make the same mistake over and over again. And so again, I think use the Great Smoky Mountains data, use a normal control sample, et cetera, et cetera. But when you look at the severely persistent people, that's what's matching up with our clinical samples. And those kids, because I've done that, and I'm going to try to write that up. What you come up with is what those predicts isn't bipolar disorder, but it isn't just depression. It predicts continued disruptive behavior. The zebra doesn't change its stripes. Those kids do not grow up to become sad, depressed, anxious people. They continue to have problems with mood regulation. They continue to have problems with ADHD-like symptoms. They continue to have problems, the same problems as they have in kids, because it's the top 2% of the sample. So just to reiterate, I think we need to focus on those kids. I'm going to try to do that, and we'll recruit some of you to help me out with it with my initiative. We need to read the literature and look at the samples that are being studied, look at the way they've studied them, and factor in the fact that severity makes a difference.
And Gay, I'm going to actually take a page out of your book, Gay, if you don't mind. You asked for precision at the start by calling this mania. One of the things that we intersperse, and I think we use the term differently amongst ourselves, is the term irritability.
Yes.
Now, irritability, as I have always thought of it, is a mood symptom that is present most of the day, regardless of circumstances. Now, that's very different from reactivity and explosivity, where you have a youngster who is, how did you put it? You say this all the time, butter wouldn't melt in their mouth, cool as a cucumber, doing just fine until you trigger them. And in the way I always think about it, those are not irritable children. They are reactive, they are explosive, but irritability is reflective of a mood disorder, which is a condition of homeostasis, not a disorder of reactivity. So from my perspective, our field needs to come to a consensus of what is irritability and how is that defined, and what is reactivity and how is that defined. I think of them as two very separate entities, but I think our field oftentimes mixes them together, and I think that precision may be helpful. And again, I've already said my biases. I'd be curious what Ben and you and others think about that distinction, because I think it's an important one.
Well, Bob, I would say that I think our field has come as far as it's going to come with nosology and phenomenology and the use of language to describe symptoms. That's my own view. And I think we haven't talked about biology so far. And I think that all of these debates, they were what drew me to this field. They were fascinating and compelling. But it hasn't been my impression in the past decade. We're talking differently about these terms, and I think maybe we should take a minute and talk about what we do know, and just to plug Bob, the amount of clinical trials that are now converging pediatric bipolar with adult bipolar disorder is mounting by the year. So we're looking at acute lithium studies, most recently published online, a maintenance lithium study. Lamotrigine seems to work in an adolescent group, antipsychotics work, lurasidone for bipolar depression. So I don't know if people that are joining on this know all of that, and if we're just talking about the controversies about when we name things, I think we'll miss an opportunity to educate about how far we've come in the treatment of clear-cut bipolar disorder in young people.
Yeah, Carmen, do you have a comment? I think you can speak. Carmen, are you able to? Okay, great.
No, I cannot.
Oh, no, you can.
Yeah, you can. We hear you. Go ahead.
You can. Okay. So I really think that focusing on biology is. No, I cannot hear. So focusing on biology is something we should do. I also agree that a lot that we already know about biology of bipolar disorder, and that we still are far from having enough treatments, or to know enough about the treatments and how the treatments should be used. So that's another problem we still have. So there's a lot to know about how to diagnose these kids that are in between, or these kids that are mood dysregulated, or those kids that are chronically irritable. But on the other hand, we've got these kids with bipolar disorder, and we still do not know enough, based on data, on how to treat them. So we are faced to have knowledge based on short-term trials. We are faced to trials that are based on particular countries and not widespread. So that's another interesting thing. Some people do not really trust trials depending on where this trial have been performed. And we still do not know enough about longitudinal. And what is else? There's maybe some questions that are not being asked with clinical trials, not with longitudinal follow-up clinical trials. We should know more about registries. We should be using other strategies that we may have for knowing what's going to be better for these kids in the long term. So there's wide possibilities that are underused for the particular case of bipolar disorder. And maybe these hangouts on forums like this ones are good opportunities just to try and see whether there are possibilities, just to start doing internationally or worldwide initiatives, just to learn a little bit more on what we already are doing in the clinic and the knowledge we may gather from that.
You know, Bob and I were involved some years ago in a failed trial of trying to get the FDA interested in how to manage impulsive aggression. And as you were talking about irritability and so forth, I was thinking about, yes, it's a difference between, I think of a bomb. Irritability is how long the fuse length is of a bomb. The reactivity is sort of how big is the explosion and how long it lasts. That really is often aggression. And I think the FDA's loathness, I don't know, their reluctance to sort of do something about that irritable aggression business has not served us in good stead. We need better treatments, we need better drugs, we need to be able to define the population, because, and this is what I'm thinking about with my initiative, and maybe you guys can help me with it. What I'm thinking about is there a difference between the reactivity of a manic kid, or the reactivity of an ADHD kid, or the reactivity of a PTSD kid, or a reactivity of a kid who's been, doesn't want to be separated from his mother or whatever? Is there a difference in those reactivities, or is it like a fever where, yeah, you can have the difference between why you have a fever and, pneumonia or syphilis or whatever the thing happens to be, but you can still treat the fever even if the etiology is different. I don't know, but I agree with you that we do need to come up with treatments. These are very disabled kids, and they make a mess out of their lives and society's lives, et cetera, et cetera. Is there a difference in their explosive reactivity depending on the diagnosis?
Yeah. Anybody want to comment?
Well, I think that the issue of semiology and reaching a consensus in terms of the description of the semiology, the terms we use, is really key. Actually, also what has contributed in part to the confusion has been really a different use of terms. For example, pediatric bipolar, does it include or not adolescent? So we should move over to really a consensus and terms which are shared consistently.
And I guess to the topic of today, which is bipolar disorder, to Ben's point, when we talk about irritable mood, which is a symptom of characteristic of pediatric bipolar disorder or bipolar disorder, if you're talking about a homeostatic state, irrespective of stimuli, that's very different from a state that is only associated with reactivity. And so in many ways, if you're saying reactivity is irritability, well, then a lot more people are going to have pediatric bipolar disorder as opposed to it's a homeostatic state that is present regardless of external stimuli. And when I do our research, and many of my colleagues do it with me on multiple site studies, we define irritability as a homeostatic state, irrespective of stimuli. Yeah. But not everybody obviously thinks that way. And that changes the prevalence of pediatric bipolar disorder.
So my solution to what Sam just said is to say, rather than pediatric, the way the schizophrenia researchers do, they say early onset schizophrenia is below age 18 and very early onset schizophrenia is below the age of 12. So for me, if I ruled the world, I would say we should make that distinction of very early onset and early onset. As far as irritability is concerned, I would make the distinction between how you feel and what you do. But I can say, having seen some pretty irritable manics, that even though butter wouldn't melt in their mouth when they're in a euthymic state, when people are manic, they become irritable. Their homeostasis changes, and they may be perfectly charming as long as you agree with them. It's when you disagree with them that you get a punch in the nose. They are irritable in that state. The difference is chronicity. The difference is who they are versus what they have. What they have is mania. If they're chronically irritable, maybe that's who they are. But I think irritability does vary with the condition that you see it in. I would make the distinction between how you feel. You feel grumpy and irritable and as opposed to, you can go as opposed to punching somebody in the nose. That's what you do. That isn't irritability anymore. That's what you do with your irritability.
Precisely. I agree with you. But the field, the field grapples, and that impacts who gets the diagnosis of bipolar disorder.
Yeah. So maybe one of the things that we can do, if I get this initiative off the ground, is come up with some definitions that we can agree on and ways of measuring them, so that we can at least have some language that we're speaking of in the field that isn't a Tower of Babel, which is sometimes the way things get.
Sorry, may I make a provocative comment as an innocent bystander to this conversation? So, I mean, it's very interesting and fascinating, and I totally agree that we need to improve diagnostic tools and also how we define the different dimensions. But from the perspective of patients and possibly also clinicians, all this discussion, what for? I mean, are we talking about more specific treatments or individualized, personalized treatments or dimension, or deciding which approach to use, pharmacological versus non-pharmacological? I'm saying this because with my field of expertise is evidence synthesis, and now we are moving from averages to individuals, and also within each intervention, we are trying to identify which are the components of the specific intervention in order to tackle specific dimensions. Now, just a comment.
So what Carmen said, I think, is relevant. Ironically, aggression, I'm going to use that term, lithium is quite effective with affective aggression, as are the atypical antipsychotics, as is our stimulants. So we have the same nails or the same hammers for these nails. The difference for bipolar disorder and whatever this diagnostically homeless thing is the question of what you tell the family about the outcome or the prognosis is going to be. If I know somebody's got manic depressive illness, what I say to the family is very different from what I say to them if they've got this, emotionally reactive ADHD, labile, blah, blah, blah state. And it's because it's the best I can do with it at the time. But that's where the treatment difference is concerned. The drugs aren't that different.
Well, and let me interject. We had one comment on Twitter about diagnosing this disorder as little as possible and not using, quote, toxic, unquote, antipsychotics. And so I think there is an important point about making sure there's a match between the medications that we use and the opportunity for them to be beneficial for the person to give them to, and for what Carmen talked about how long we treat people for, right? So are we giving people decades of treatment for a problem that may require shorter term intervention? How do we assess that?
So how long is the person sick? You know, I go on both sides with that antipsychotic business. These kids are being thrown they're being put in hospitals. They're being taken to emergency rooms with handcuffs. They're being kept out of classrooms because they are so disruptive. I'm going to say to them, oh, I don't want to give you an antipsychotic because it sounds terrible. I need to be able to get that kid into as normal a state as I can get him, as quickly as I can get him there, and for as long as he needs to be there. And it's not a big mystery if the kid suddenly is giving you the hallelujah chorus and the sun is out. I don't keep him on all those medications. I don't see many kids that do that. But if I do, I'm treating the impairment. I'm not treating some philosophical thing here. I'm treating the impairment.
I think that's very on the ground, honest, and to the point, and really important for you to say. Ben, you have a smile on your face.
I was just going to say here can only be said that way by Gay Carlson.
Yeah, I think it's brilliant. Carmen, do you have a comment?
Yeah, I really think that in a wonderful world, a patient will be treated by someone and pass all the information in a very good way to the adult psychiatrist that's going to see him or her afterwards, and people will go on with what you've done and will understand. But my impression is that there is a huge problem when these kids become adults, and many of my patients have come back to me after being stabilized for a while, which may be a problem because there's no impairment apparently for a while when they are 17, 16, 17, after maybe turbulences in early adolescence or late childhood. And you go to adult psychiatrists, and all these disquisitions that we may have really are others for them. So these kids are diagnosed with personality disorders, or these kids are diagnosed with other stuff. They're taking off mood stabilizers or medications that we've been using, and this is also a problematic thing. So I really think that the long-term follow-up is a problem, at least in my national health system, because the system is a system, and it has many people in and out, and going to the practicalities is problematic.
Yeah. Well, we're coming to the end of our hour. I will give the last word to Bob, since it's his paper. If you please, a comment you want to make to wrap this up. Not enough time to talk about this topic for sure.
Well, thanks for the comment. First of all, thanks everybody else for joining us. As you can see, reasonable people who are intellectually interested as well as clinically interested in these very vulnerable young people have a lot of common ground, and that is the only way for us to move forward, which is together. And that's the only way to help these kids, not by fighting with each other, but moving together.
Right. Well, I wanted to thank everyone for joining us. I want to remind you that all of these Hangouts are archived on our YouTube page at Evidence-Based Mental Health. I want to thank everyone for joining. Bob Findling, Gay Carlson, thank you so much for taking time out to do this. Ben Goldstein, an old friend and colleague, Carmen Moreno, thank you so much for working through these difficulties technically to join us. Samuele, Cortese, and of course, Andrea, Cipriani. I'm Michael Ostacher from Stanford. Thank you, everyone, for joining us today.
Thank you for having us.
Bye.
Nice to meet you.